disclose today. And I'm happy to bring up our first speaker, Dr. Paresh Shah, who's Chief of Minimally Invasive Surgery at North Shore LIJ's Lenox Hill Hospital in New York City. He's going to be speaking to you about meaningful use of electronic medical records, hopefully demystifying some of this for you all. Thank you. Paresh.
Thanks, Ron. Thanks, Mike, and thank you for the program committee for inviting me to talk to you this morning. These are sessions that invariably engender either fear, disgust, loathing, or anxiety, or some combination of all of the above. And I'll endeavor to make this one no different. Let's see, here we go. My disclosures, there are no direct conflicts of interest with any of these relationships, and as a continuing disclosure, the reason I'm up here, I think, talking to you about this is that in a past life, I spent a lot of time in the world of medical informatics as the CMIO at the Lady Clinic, and I was a member of the Presidential Task Force on Healthcare IT a few years ago. So while you amuse yourself with this cartoon, I'm going to preface the discussion around why are we even talking about this and what was the motivation behind the concept of meaningful use. And it has to do with two primary factors. The first is this slide, which many of you may have seen in the past, which is a reflection of the expenditure related to healthcare dollars that we in the United States are undergoing. And these curves are unfortunately very steep and getting steeper. So the cost of care is clearly a major driver. And the other is summarized, I think, nicely by this cartoon, which is medical error. And medical error, but as part and parcel of the concept of medical efficiency and improved outcomes. So that led to this concept of meaningful use. Those were some of the drivers behind it. And this depicts a general timeline of how meaningful use intends to be deployed. The goal here is, as depicted at the end, clearly improved outcomes for our patients and an improved process of care in the delivery of health care in the United States. And the process to meaningful use begins with capturing data, understanding what we're capturing, and then having that support better processes of care, which then result in improved outcomes. Now, just as a show of hands from the people that are here, how many of you are actually aware of what meaningful use is in some general sense or form? So it's only about a third of the people here, so that means that I'm here for a good reason. The background to this is that the ARRA, which was signed into legislation in 2009, specifically included the term meaningful use. And what it refers to is that all healthcare providers and hospitals have to demonstrate meaningful use of a qualified electronic health record system, or EHR. And I'm going to get into what that means in just a minute. But the idea was that we recognize that the electronic tools are going to help us if we use them properly and if they're designed well. And so the government is incentivizing us to use these tools, aggressively, frankly, incentivizing us to use these tools. But along with that carrot comes a stick. If by 2015 you have not started to use these tools, you're going to get whacked with a reduction in payments for Medicare-related services. And those reductions increase over time the longer you're not using these electronic tools. The practices in hospitals that already have an electronic medical record system may qualify for the incentive payment, provided that that EMR or EHR meets the criteria for meaningful use. So to give you a sense of the dollar amounts we're talking about here, $47 billion out of the ARA was allocated for healthcare IT. Of that $47 billion, $45 billion is incentive payments. So that's the check that the government's writing to healthcare providers around the country. And $2 billion was allocated towards creating the Office of the National Coordinator to administer this process. And another $300 billion, which is chump change in these numbers, for regional health organizations. So the ONC is the office that administers this. This is the office that actually generates the proposals and the rules that will go through defining meaningful use. So what are they? The idea of meaningful use of a qualified EMR, the first question is, what is a qualified EMR? It means that it's an electronic record that can do a certain number of prescribed things. It has to be able to capture patient demographics, it has to be able to capture clinical information, it has to be able to provide decision support at the point of care to the providers. It has to support computerized order entry. It has to be able to be used in a prospective and retrospective manner to analyze your existing patient population, to query the quality of the care that you're providing, to basically understand and ask questions about the quality of care. And lastly, that it has to be able to exchange that information with other EMRs or EHRs, whether they're in other facilities or as part of a regional health organization. And the congressional requirements are that you use one of these certified records in a meaningful way. And the definitions of what's meaningful I'm going to get into now in a minute. So the criteria come out in 3 stages. Stage 1 was released in 2010 for public comment and then approved to begin in 2011, which set the baseline for electronic data capture and information sharing. Stage 2 was actually just released last week. And I've got a little slide on that, which is the next set of recommendations. And then stage 3, expected to happen by 2015, which will then define the terms for the future. Meaningful use for stage 1 meant that there was a core set of objectives that you had to meet, and then a menu set from which you could pick any 5. I'll show you what they are in a minute. And this is for providers or eligible professionals. An eligible professional can be a surgeon, a doctor, a nurse practitioner, a podiatrist, any care provider. And then the hospitals have a different set of rules. They have a different set of objectives and a different menu of optional objectives as well. So the core set for providers in stage 1 was the use of CPOE, the use of electronic prescribing, checking for drug interactions and allergies, maintenance of a medication list, maintenance of an allergy and problem list, integrated decision support to help you pick which medication to use or which drug to order, recording demographics, smoking being a vital sign, recording smoking status, being able to give these summaries to the patient, being able to give the patient a copy of their record, and then exchanging that information as well. And lastly, the quality measures and the privacy measures around protecting that information. So these were the core on the left side blue column is all the things you absolutely had to do. And then the menu on the right side in orange are the things that you could pick 5 from. And you could pick any 5. You got to choose which 5 you picked based on your patient population, based on your practice and your demographic. But once you picked them, you had to stick to them and stay with them. For stage 2, to give you a sense of how things have changed, instead of 15 core objectives, there are now 17. Instead of 10 menu optionals, there's only 5 menu optionals, and you have to pick 3 of them. So instead of a minority, you now have to pick a majority of those. The number of clinical quality measures have increased from 6 to 12. And the way these metrics were designed was that you had to do it for 50% of your patients for demographics, 40% of all of your prescriptions, 30% of all of your orders had to be done electronically. Now for stage 2, those numbers all get ramped up. 80% of all of your patient demographics have to be electronic, 65% of all of your prescriptions, 60% of all of your orders, et cetera. And so stage 2 is basically just ramping up the degree to which you have to have all of your patients and all of your clinical data done electronically. The clinical quality measures for eligible professionals, you got to pick 6 of them, 3 required core measures and others that you could pick from a menu of 38. And I'm not going to list all of them here. They're pretty extensive. And then the hospitals had to report on all 15 quality measures. They didn't have anything optional in terms of quality. There were a lot of controversies and a lot of things that were unclear in the process of the meaningful use criteria. The first was, what defines an eligible professional? What do you have to be in order to comply with this? And are there ways that you can opt out or be exempted from compliance with meaningful use? The most common refrain from surgeons is, I don't do any prescribing. The only thing I prescribe is Percocet, Vicodin, and Colace. So e-prescription shouldn't really apply to me because I'm not writing hypertensive meds and diabetic meds and anti-rheumatology meds. But the fact is that if you're, and so they've addressed this with identifying minimum numbers of prescriptions that you use. What if all of the work that you do is in an outpatient setting and you never walk into a hospital? Or what if you work at 4 different hospitals as well as an ambulatory surgery center and 2 private offices? Where do you have to comply with meaningful use? And the short answer to that is the 50% rule. If there's any one practice location where 50% of your time is spent or 50% of your patient encounters occur, irrespective of time, that becomes the environment wherein you have to demonstrate compliance with meaningful use. The reporting mechanisms weren't defined at all when Stage 1 for meaningful use was published. They're becoming a little bit more clear now, and as it turns out, CMS's estimate is that it takes between 8 to 10 hours per month of man-hour time, work time, whether it's you or your staff or whoever else, in order to comply with the reporting requirements. I think that's a low ball. And I think it's actually going to be much more than that as the requirements become more stringent. And unfortunately, meaningful use is an all or nothing approach, which means that you're either complying or you're not. It's kind of like being pregnant. You don't have a choice. So the question is, are you ready? And the immediate question that brings up is, do you have to get an electronic medical record? And to paraphrase Homer Simpson, duh, yes, you have to get an electronic medical record. And to give you a sense of how far behind we are in this, based on size of practice, this is from the New England Journal of Medicine in 2008, looking at penetration of electronic records in the provider environment. Only 13% had a basic system, and only 4% had a fully functional EHR system in an outpatient environment. This was in 2007. And practices that were less than or 1 to 3 physicians, which is the majority of surgical practices in the country, less than 10% had actually implemented an EMR. That number has improved a little bit, but not a lot. This is a bit of a busy slide, and I don't expect you to read any of it, but the idea here is that under the new Stage 2 definitions, you're allowed to have modules of an EMR and put the modules together to make a whole EMR. And this gives you a sense of how many or how much each module is perhaps penetrated. And it starts on the far left with clinical data measures, data review, and all the way on the right to regulatory reporting. And basically, we haven't achieved 100% penetration on any single module in any environment, let alone getting enough of them to even the 50% mark. So this is more current data. This is as of just this past November. Coming out of the government data, which shows that EMR penetration in office-based practices has now reached about 50%. And that basic systems are gradually moving up, but fully functional systems still less than 10%. So we're a far cry from what you need to have in order to comply with meaningful use. The concept of a qualified health record, though, brings into the equation who qualifies it. What determines that it's qualified? And so there is a process determined by the legislation for how to do that, and that's under the purview of the ONC, the Office of the National Coordinator. And it's created a process called CCHIT. The other thing that you'll learn in this is that there are more acronyms than you can possibly remember, and they're all blending into one another. ARRA, PPACA, CCHIT, ONC, oh my God, it gets really carried away. But the certification process for health records is a well-defined process, and it's the vendor's responsibility to get certified, but it's the provider's responsibility to make sure that what they use is truly certified. And the criteria for certification are a moving target. They've changed from Stage 1 to Stage 2. And the reason this is really important is that you as a surgeon or as a practice will buy an EMR, and the vendor will tell you, yeah, we are certified for Stage 1 meaningful use. And then when it's not, the vendor's not liable. The government's going to go after you. You're going to be the one that's non-compliant. So it unfortunately does put the onus on the practice and on the provider to make sure that the products that they are using are truly certified. Let's skip ahead for a little bit. So it is time to get off the rest stop on the information highway. we have to get back on. If you are not electronically enabled in your practice, you absolutely have to be. This is actually a little bit old of a slide because when I wrote this last year, I was saying within the next 12 months you should all be live with an EMR to maximize your incentive reimbursement. Well, that started in 2011. So you should have already been on one, and if you're not, you've lost out on that first year of incentive reimbursement. I'm going to show you what that is in just a minute. But if you don't do it by 2015, not only will you lose any of the potential incentive reimbursement, but you're going to then start to get penalized. So the pathway and the timeline for meaningful use started back in 2009 when high-tech passed and the policies were initially defined. The first stage was released in 2011. 2013 is when stage 2 goes live and active. 2015 is when the criteria are completely fulfilled. And you've got to increase the amount of reporting that you do. Right now, we're still in stage 1. Stage 2 guidelines have just been released for public review, but they will go live by next year, and you'll have to be compliant with them to get paid. And this is how much you get paid. So if you're a practice that was compliant with meaningful use stage 1 in 2011, you would start to get $18,000 a year. And the total sum of payments, $18,000, $12,000, $8,000, et cetera. But the government's allocated $44,000 per provider to defray the cost of converting to an electronic record system. And that was based on calculations they did that estimated that this would be about 80% of the true cost of conversion per provider. So it's not going to pay for the whole thing, but it will go a long way towards defraying that cost. And this is frankly money that you are literally leaving on the table if you don't have an EMR system deployed that is a certified EMR. The payment score for Medicaid is actually even more than Medicare. And again, like with everything with the government, you can't double dip. So you're either going to comply with Medicare or you're going to comply with Medicaid, and that's really based on what your patient population is and what your practice environment is. If you are in a Medicaid-dominated area, then you should apply for qualification through the Medicaid process, and you actually get a higher total net reimbursement, or incentive payment, I should say. It's not really a reimbursement, it's an incentive payment, up to $63,000. So what do you need to do? Well, 2 years ago, ideally, you should have chosen an EMR. If you haven't, it's still not too late, but you do need to do one. First, pick one, and there's a lot of resources, and it's beyond the scope of my talk today, but I'm happy to discuss at length the process of selecting an EMR. Then you got to implement it and train your staff in using it, and make sure that it can do the reporting required for stage 1 and now stage 2 for meaningful use. You've got to utilize all of these measures for at least 90 consecutive days and then report them. You pick the measures that you're going to report on, you pick the patients that you're going to measure, and then you have to do it for 90 days and send the report into CMS. Once you've done that and you attest that you're complying with meaningful use, you'll get paid. It's worth noting payments have already started. CMS started making payments in the fourth quarter of 2011 to practices that were able to demonstrate compliance with stage 1 and actually generate reports. So the payments are coming out. How do you get paid? It's being done through your NPI numbers. It's going to be a single annual payment. Medicare will pay through CMS. Medicaid will pay through your state Medicaid organization or provider. And as the next stages of meaningful use are rolled out, each reporting period, they will make rolling payments to catch up with them. So the payments can be reassigned to any entity with an employment agreement, but you can't split it amongst them. So what that means, and this is a little obtuse, but if you're part of multiple organizations, you can't split your payment across those multiple organizations. Only one of them will actually get the payment. And this goes back to the 50% rule I mentioned earlier. If you're in 3 or 4 different practice environments, only one of them will be the one through which those payments are channeled. It can't be split across them. And there is a single database that the ONC is managing to track participation in those programs. So this was a very brief 20,000-foot overview of what meaningful use means. And this is a 3-day-long course if you really want to get into the depth of it. But I wanted to give you all this overview, and I'm happy to entertain any other questions with regards to it. I do have other slides on this pack, which I'm happy to make available through the SAGES website, that go into the specifics of what designates a qualified EMR, the specific components, as well as what the various payment schedules involved are, and some more details around what Stage 2 recommendations are. Thank you.
Thank you. We'll entertain a few questions from the audience for Paresh. Paresh, I have one question in particular. Is there a difference between inpatient and outpatient EMRs? For example, a private practice physician may only work part-time in a hospital using the hospital's electronic medical record. Do they need to have a separate EMR in their office?
Yes. For the purposes of meaningful use payment, if as a surgeon more than 50% of your clinical care occurs in a hospital setting, that may be enough for the hospital side, but you should have an office EMR as well. You're going to need to have one regardless, because even if you're not interested in the incentive payments, even if you're not interested in anything else and you don't participate in Medicare and you're not going to take any Medicaid patients, you're still going to need to have the EMR for the data exchange, which is now a federal mandate. So in order to comply with data exchange requirements, you're going to have to get an EMR in your office. Maybe not in as much of a rush, but you're going to have one.
Thank you.